obesity? Is there some factor for it? They couldn't find one, but increased rates of atony and increased rates of transfusion to match it. Interestingly, this is their data set. I'll point out a couple things on it, or this is one of their data sets. A lot of the things that we traditionally think of as risk factors for atony in particular probably aren't. So one of the ones that's actually a bit controversial in the literature is oxytocin exposure. So multiple studies now, I think that the consensus is that oxytocin where the confusion has been in the past. So most women who receive most normal doses of oxytocin, it doesn't pan out that there is an increased risk of hemorrhage. But high dose for induction or augmentation of labor, high dose oxytocin regimens apparently are. But even at that, if you look at oxytocin exposure, even, and this table doesn't break down dose dependency, but if you look at it, a lot of the things that we think of as traditional sources of hemorrhage, and they focused on atony, but this has all sources of hemorrhage in it. A lot of them are not really, if you look at the adjusted odds ratios, are really not that significant. And you see that actually oxytocin augmentation was associated with a reduced risk. And that's actually what most studies have shown. But if you get into larger doses, it becomes a problem. But the things that, if you look, this odds ratio table here is better than the adjusted ones. If you look at the big ones, obviously they're structural. So cervical lacerations is the leading one. When you think about it, that's where people get in trouble. They have an undiagnosed cervical laceration, and 4 hours later they've been given uterotonics and blaming that oxytocin, and the fact was there was a 2-centimeter cervical laceration that they never repaired. Their C-section rate in the time period went up about 30%, and so this includes those deliveries, so you'd expect some increased hemorrhage related to that. But they found no trends other than it's happening more. And one thought that they didn't really address is maybe it's happening more because we're diagnosing it more, and that'll take us to Dr. Jernigan's article in just a minute. Controlled cord traction. So different article. These are just one after the other. What's called active management of the third stage or Brandt-Andrews traction is widely accepted as one of the leading things we can do to prevent maternal death worldwide. And that includes, a part of active management is starting Pitocin as soon as the baby's shoulder is delivered, not waiting until after the placenta, as soon as the baby's delivered. And then cord, what is called Brandt-Andrews traction, just putting your hand in the lower uterine segment, not massaging, but putting your hand there to prevent eversion of the uterus and controlled traction. Well, these authors wanted to find out which parts of that actually matter. There are some better studies coming out now about how much oxytocin we should give, and oxytocin versus maybe other uterotonics for preventing hemorrhage. So they broke down, they just had people do the cord traction or not do the cord traction, but everything else is the same. They still got Pitocin, they still got all the other parts of active management of the third stage, but they didn't have that active cord traction. And they found that it did not reduce the rate of hemorrhage. However, it did reduce the need for manual extraction by about 50%. And it reduced this at the prolonged third stage. The outcome they actually looked at was greater than 15 minutes. So when women had cord traction, only 4.5% had their placenta for 15 minutes, as opposed to 14%. And I think they were a bit surprised, less maternal discomfort and pain. Maybe that's related to just it's happening quicker and it's not sitting there undiagnosed and whatever. But so they still advocated for controlled cord traction, but just intellectually, that's not the part of active management that's delaying or reducing hemorrhage. This is the study that Dr. Jernigan showed me yesterday. Or was it yesterday?
No, it was. Wednesday. We talked about as we were starting the discussion on the students' test.
So this actually just came out in June in the Gray Journal, and these folks. They looked at, in their own institution, they went back and they did a case control study with 800 patients, and they looked at who got CBCs and what their other characteristics and parameters were. So these are postpartum or post-operative C-section CBCs the next day. And they found that if they moved towards a protocol of only order the CBC if the patient has tachycardia, oliguria, orthostatic blood pressure, symptomatic, she's lightheaded when she stands up, to go to the bathroom, whatever, they found that they reduced their transfusion rates from 5.5% to 1.7%, which is a really substantial difference. And just in 800 patients, they saved their unit $58,000 when you count the transfusion costs and that. Interestingly, in their data breakdown, I'm not sure if I have it on the next table or not, if it's the right table, but they actually had, although it didn't pan out to be statistically significant because of the number, the patients who didn't get CBCs went home sooner. And that's probably part of the cost issue there too. Well, her hemoglobin's 7.2, let's watch her another day and do another one tomorrow, and oh, it's 6.8, let's transfuse her and keep her a third day, and that kind of thing. And so their conclusion was you shouldn't get CBCs really on anybody, post C-section or post-vaginal delivery, that were in essence harming the patient with prolonged length of stay, unnecessary transfusion, increased cost. And instead, your choice about doing a CBC should be based on your clinical assessment of the patient.
And things like this are going to start playing more of a role in literature. Your studies are going to be looking at, can we eliminate certain things effectively without causing patient harm?
Yeah, $58,000 in these 800 patients for our unit, if you extrapolate those numbers out, that's near $100,000 of savings a year. That's significant over a little checkbox on the order set that, we just choose to check or not check.
We have suggested that to the United States as our cost reduction and saving resident physicians.
Yeah, it's $100,000 potentially.
As insurance company just sent out letters about, monitoring cost efficiency of
Placenta accreta, and of course with the exploding C-section rate, this is the story of the residents' generation. Older data, that, if you look in a Williams from, say, 10 years ago, the incidence of accreta that they cite is in the order of 1 in a couple of thousand. This study actually this is out of Utah, which has one of the lower C-section rates in the United States, already had it in their population at 1 in 533. So in a place like New Jersey with a 39% C-section rate, it's probably significantly higher. And it's just going to compound, obviously, as the section rate goes up and more repeat multiple sections. But in their 141 women that they identified who'd had a history of an accreta out of their population, basically they looked at, should this be something that you do planned in your community hospital, and this is the only cesarean hysterectomy, or it doesn't have to be hysterectomy, but whatever management you're going to use, it's the only one you're going to do that year, or should you go to a tertiary facility with a multidisciplinary team? Their definition of multidisciplinary team, of course, was an in-house OBGYN, 24 hours a day, in-house anesthesia, a blood bank with transfusion and mass transfusion capabilities, and availability of somebody else, like a GYN oncologist, or maybe it could be your trauma surgeon or somebody else who is sort of been tagged as, hey, if we get into it, we're going to call you and you're available 24 hours a day. So, and they reduced overall morbidities. It wasn't anything particularly special. It's not like they were bringing them in before and pre-transfusing them or doing, this was just who's doing the surgery and is a team there who's done this before and is ready to work together. And they reduced composite morbidities by 80%. And the big reductions were things like need for transfusion. Reoperation rates were surprising to me. I think in the first 24-hour reoperation rate that they observed in their multidisciplinary team was about 4%. And in the community-based team, it was over 30%. I don't remember the exact number. 30%. That was surprising to me. But, if you can imagine, you're in practice in a small community hospital and you're by yourself at 3 a.m. and you've got one of these and you haven't done one in 4 years or maybe since residency or maybe ever, and you're probably going to have a lot more anxiety and whatever. So they had a over 30% reoperation rate in the first day in the outside facilities. So bottom line is, people who practice outside of an environment like this should probably be referring all of their suspected accretas to us. Ultrasound diagnosis of accreta, early ultrasound diagnosis, would help them do that. This paper in the Journal of Ultrasound Medicine, this is a small paper, but it's really interesting, and I think that this will probably be expanded, and this is sort of, hey, look for this, and let's see if we can get some more patients. It was only 10 patients, but it was a really good paper. And they were trying to see basically at 10 or 11 weeks, can we take a person who has risk factors for accreta, a multiple section or two or whatever, and just with their first trimester ultrasound, can we sort of predict who's going to have it? And they were very successful. 10 patients, very successful. And of course, they don't give us a comparison of how many other people they thought had one. And I'm sure there were a significant amount, but then those people would progress, and with later ultrasounds or MRIs, they would rule them out or whatever. And some people you're going to open up and you think they have one and they don't. But the point was to identify people early on, and that way we can funnel them into the right pathway. So they looked at this early ultrasound, whether or not the gestational sac was implanted low, any anechoic areas in the placenta. They had 4 things: an irregular myometrial interface, and then did they have a placenta previa. And of these 10 folks, all of them had at least 3 of those. The one that was least common was placenta previa. There were only 7 with a previa. But all of them had at least 3, and all of them ultimately had a histologically proven accreta. So that's something emerging. I don't think anybody's doing that routinely, but people are going to look for ways of risk stratifying these folks, especially if we're going to say that they all need to be referred to a center that deals with it routinely. Okay, aneuploidy testing. I have to keep track of my time. So, the big thing since my last OB Potpourri is cell-free DNA, and in some form of that, and some fashion of that, the literature, I could get 50 articles where people have looked at that. There are 2 articles, though, and this is one of the 2. There are 2 articles, though, that are probably the ones you really should read. This one in particular, warning people caution. The problem with cell-free DNA, it's a fantastic test. And 5 years from now, 10 years from now, I can't imagine what we're going to do with a drop of blood, maternal blood, and be able to test for. The problem with it is people are so convinced by the companies that sell these products that it's such an amazing test because it has a 99.5, 99 point whatever percent sensitivity and specificity. They think of it as replacing diagnostic tests. So a couple of years ago in the Green Journal, there was sort of an editorial comment of, everybody needs to slow down here a little bit and understand this is not a diagnostic test, it's a screening test. And then this paper is really good. This paper, they didn't go so much into the stats. The other one went into the stats. Bayes' theorem, if you don't know, is a fundamental theory of statistics. Those of you who hear me talk all the time know that I think this is the most important concept in medicine. But this paper actually presented 8 cases, and it's really interesting to read. They present 8 cases of folks who had false positive diagnoses of either trisomy 13 or 18, and they give the whole clinical picture, and they speculate as to what some of the etiologies may be. And they point out that the companies are not taking registries of false positives. They're not providing, I actually looked on the websites of a couple of them. Some of them do provide a positive predictive value, but you can't provide a positive predictive value for your population. They can only provide it for their study population. But physicians who don't understand Bayes' theorem and understand the impact of pretest probability on positive predictive value are thinking of this as a universal diagnostic test that should be applied pretty much to all populations. I know 20-year-olds who are getting it to find out the gender of their baby at 11 weeks. Oh, it's a great test, and I don't have to think about all that other risk stratification stuff with first trimester or quad screening or whatever. So there's these cautionary papers are coming out, but just to save you the math, if you want the formulas, I'll give it to you. But this is from Harmony's data. They all have a little bit different data. But, I should have had these not pop up and then ask people with an audience response system to give me the numbers. But the company comes and says, this thing is 99.5% sensitive and 99% specific. And your test is positive for Down syndrome. But Bayes' theorem, in a 20-year-old, what that means is that 20-year-old actually has an 8.5% chance of having a baby with Downs. In a 35-year-old, it's only 27%. And in a 40-year-old with a 1 in 70 rated Down syndrome, it's still only 59%. So in all populations pretty much that we're testing, these are overwhelmingly false positives. Now, if you've already done a quad screen and you had a 1 in 27 chance, and on ultrasound there's some markers that increase that risk any more, and Dr. Welch says that the pretest probability for this patient is 1 in 5 or something, I would probably take cell-free as a diagnostic test. And I have a spreadsheet if you want, and I can show you what the number would be with a 1 in 5 pretest probability. But screening the vast majority of patients, it's a screening test. Now, if we take a quad screen as a 1 in 270 false positive rate, a 1 in 270 is a positive test. 269 out of 270 of those are false positives across the population. So obviously it's a much, much, much better screening test than anything we've ever had before. But it's not a diagnostic test that in and of itself should be used to diagnose these abnormalities. Unfortunately, I think the majority of practicing OBGYNs think it is because of the way it's being marketed. Yeah.
I haven't heard anybody put prices for these self-reading.
Dr. Welt may know.
2,000.
2,000.
Well, it's 2,000 to the insurance company. If nobody pays anything, your maximum personal liability is 200. But that's a deal I made with all three of the companies we work with. I can't tell you what deal they give some of these trusts.
Can anybody get that, or do you have to have risks?
Anyone can get it.
And-
It would be nice
and-
to have a reason. If you tell me I'm sending my patient over for cell-free DNA, she wants to know the sex at 11 weeks, I'll advise you against it.
Right. And this is why. This is why.
Then care's covered.
Yeah.
The companies are eating.
Okay, some operative obstetrics articles. So adhesion barriers, we've talked a lot about those. None of us here, I think, are using them. But it's interesting. This was a review article from 2011, actually. It's a couple of years old. But they, surprisingly, I didn't know how little data there was. There were only 2 studies with a total of 35 patients ever where a woman had a C-section, had an adhesion barrier placed, and then had follow-up to see if she had adhesions less or more than the other person. So all of you have done enough repeat C-sections to know there's no way you can conclude that adhesion barriers work with having looked at 35 uncontrolled patients. So it's really just ridiculous. And these are studies done, by the way, by the companies that sell these products. And that's for C-sections in particular, but even out of C-section arena, there's really no data that they work. By the company's data, it's estimated that you would need about 2,000 women with C-sections to treat to prevent one significant adhesion. But that's like, I actually had bowel adhered or something like that, one significant adhesion. But even that's an extrapolated number from a data set too small to make that conclusion. And they're very expensive. And so this is yet another review that says we probably really should not be using adhesion barriers at the time of C-section. Dr. Welt and Dr. Jernigan will appreciate this article. This author actually has several good articles, this team of authors, and this was just one out of the group where they're looking at different subsets, but they went back over a several year period and they have 1 million births in this registry from New York City. It's over several years, obviously. And in this particular study, they had 15,000 forceps deliveries and 18,000 vacuum-assisted deliveries and 87,000 C-sections. And most of their articles are interested in complications and neurologic injury. I wanted this one because I wanted to point out their main conclusion was forceps result in less neurologic injuries than C-sections do. And also than vacuum, this is the part Dr. Jernigan and Dr. Welter like, also less than vacuum deliveries do. And here's their data. They presented this in several different ways. Yeah, they presented this in several different ways. This is forceps compared to vacuums. So obviously, facial nerve palsies are more common with forceps than vacuums. And brachial plexus injuries, I'm guessing you pulled yourself into a good shoulder dystocia there, are a little bit more common. But all the other outcomes, depressed APGAR scores, neonatal seizures, obviously the hemorrhages, encephalomatomas were all less than the forceps. Okay, but here's forceps compared to C-section, right? Because we're in this era where our forceps now is a C-section. And so forceps compared to C-section also is associated with reduced risk of all of the neurologic outcomes. Fewer depressed APGAR scores, fewer neurologic complications, which included seizures and hemorrhage and subdural hemorrhages, and fewer intraventricular hemorrhages. So these babies had, at 1 year and 5 years, had better neurologic outcomes compared to babies born by cesarean.
There's a delay to get to the C-section versus forceps, they're just out faster.
No, No. I mean, we don't know that, obviously, without a randomized trial. But one of the things, and I'll have a couple more things, one of the things that, of course, I emphasize all the time is neonatal outcomes, even in a controlled fashion, are 3 times worse with C-section than vaginal delivery. And I think one of the big harms in obstetrics now is that it's assumed that C-section is the safe thing for the mother and the baby. But of course, a woman is 8 times as likely to die if she has a primary C-section as a primary vaginal delivery, and her baby is more likely to die and more likely to go to the NICU, more likely to have depressed Apgars. And that's even in a context of elective C-sections. These are not emergencies necessarily, but obviously it's worse with emergency sections. Now, I'm sure in some cases, as she said, if the baby's right there and I can put spoons on it and pull it out, rather than have to wait 18 minutes to whatever to do a that section, that's the case. But in general, we really have to disabuse people of this concept, and our patients included, that C-section is better for either the mother or the baby. It just isn't. So the authors, of course, bemoan the fact that our experienced forceps operators are retiring, and that this may be of academic interest only because we're losing the skill set. So trial of labor. Obviously, this is something that I'm passionate about. Several good articles, and with the booming cesarean section rate, a lot of literature now is focusing on this. A lot of data from some of the large databases of patients looking at this. This was, I thought, a really clever article. Actually, this is my favorite article of all the ones that I'm presenting, just because I'm interested in it, I think. But what they did was they went and gave surveys, and I'll show you the survey and the questions. They gave surveys to women who were admitted in the hospital to have an elective repeat cesarean delivery versus a trial of labor after cesarean. And they asked them some questions. And here's the survey. Basically, this is not the whole survey, but some of the questions. Do you feel like your doctor or midwife preferred one method or another? What do you think your chances of success are, et cetera? I won't read them all to you because pretty much the answers are on these questions. So let's look at the questions. If I were to try for a trial of vaginal delivery, my overall chances of success are, and then these are the people who had opted for a trial of labor versus the people who had opted for an elective repeat C-section. Now, the answer is the correct answer is for most patient populations is in the 60 to 80% range. But you can see that for both groups, half of them didn't know an answer. Nobody ever told them what their chance of success were. And the least educated patients were the ones in general across the board who had chosen elective repeat C-section. But even among the people who chose a VBAC, only 11% knew the right answer. And that's a theme. The next question, if I try for a VBAC, the chances my uterus will rupture, and of course the correct answer is the first one. Most of the VBACers, well, not most, but a plurality of the VBACers were aware of the right answer. But again, among the elective repeat section group, you can see it was just never discussed with them. I mean, the vast majority of them had no concept. My recovery from a successful vaginal delivery versus a repeat C-section is the same or longer or whatever. And most people got that right. But again, surprisingly, the elective repeat section group, this is an intuitive answer. I would think that for most women, this is an intuitive answer. I don't need to be taught. Yet a third of women who chose an elective repeat C-section, and even 18% of women who opted for a VBAC didn't know the answer to that question. The risk of complications increases each time I have a C-section. Most of the VBACers knew it. And keep in mind that VBACers may be learning this off the internet. So they may not be getting this information because their doctor was better informing them than somebody else. But again, nearly a third in each group didn't know that that was true. So clearly there was no conversation about family planning size and increasing rates. The reason for my previous cesarean is important in determining my chances of a successful vaginal delivery. And most of the VBACers, 2/3 were aware of that. Again, all over the place with the group that chose that. This is your question on your thing today. Which of the following risks is greater for a repeat cesarean compared with a VBAC? Please check all that apply. And so all of these are true, right? So an elective repeat C-section obviously has an increased risk to visceral organs, but infection, hemorrhage, risk of hysterectomy, maternal death. And again, this part we really have to educate on, admission to the NICU for the baby and neonatal respiratory compromise. The neonatal outcomes are 3 times worse. The aggregate neonatal outcomes are 3 times worse in the group who chooses elective repeat C-section versus VBAC. There are no winners for the elective repeat C-section group. And you can see, especially with the neonatal complications, both groups were really not aware of that. And the folks who chose elective repeat C-section were, again, the least informed. Do you think, and the authors of the article focused a lot on this next question, do you think that your doctor or midwife preferred one method of delivery over the other? And they correlated that the most with what the individual patient's choice was. They also had some free-form answers at the end that they didn't report on, and I think that they got a lot of, this is what my doctor told me to do kind of thing as an answer. Let me go back to their original thing first. So their conclusions, and again, I think it's a fabulous article and a fabulous point, people are not educated at all. Even the people who are choosing VBAC may just be doing it because they read something on the internet or they have a provider who's gung-ho about it but is not doing education. Doctors are not educated about it. They bemoan, and several articles in the last couple of years have bemoaned the fact that since 2010 when the national conference got together and said, among other things, my favorite thing from that was, and this is a true statement, it is safer to VBAC in the United States than it is to be a primogravid in labor. You have a higher risk of your baby dying if you're a G1 in spontaneous labor than if you're a VBAC. And they made a big point of that statistically and whatnot, yet again, we've not budged VBAC rates at all. People are afraid of their own shadow in regards to VBAC. And provider attitudes, the point of this study is provider attitudes and patient education are the things that are going to change that. And somehow we have to do that. This next study looked at how much impact could we have, basically. These authors, they went back, this is from the Gray Journal 2013, they went back and looked at their own hospital's data, and they took, there's a published nomogram that you can plug in characteristics and predict what a person's success of VBAC would be. I'll give you a hint, almost everybody's success is above 70%, but they used 70% as a cutoff for you're a good candidate. And then they said, okay, of those women who by the nomogram were good candidates, how many of them actually attempted a trial of labor? And it was only 29%, so there's a lot of room for improvement. And among this hospital, there was one provider who, in that group, 63% of their patients had chosen a trial of labor. And when you took that person out, all the other providers, it was only 21%. So a lot of room for improvement. And I said trial of labor is life-saving because remember, if you compare elective repeat C-section to trial of labor, a woman is almost 4 times as likely to die if she has a C-section. So this is one hospital, extrapolate this nationally, and our lack of adoption of scientific basis of this is killing people. Okay, what if your uterus ruptures? There had been a previous good study in 2003, I think, that said that they had a large series of ruptures and said that you had 17 minutes to get the child out from rupture to avoid acidosis. This study sort of verified those results. They actually came up with 18 minutes, but basically the same. And their conclusion is similar to the conclusion previously. If you're VBACing, you at least need to be able to get the kid out within 17 minutes if you want a pH above 7. And so this paper is important because I think it's the second paper that shows in large series of ruptures that you've got 17 minutes. And hopefully we got it out a lot sooner than that. Okay, contraception. Not technically OB, but we have to deal with that when they leave here. So all the rage for the last 2 or 3 years, if you can't get an issue of the Green Journal that doesn't have some mention of a LARC, a long-acting reversible contraceptive. Here's what we've known since the early 2000s that we're just now really promoting because it's been, I think, consciously promoted by some of our professional organizations. And so lots of data comes out. This is low-hanging fruit, I think, for researchers. And this is another piece where provider education seems to be the problem, particularly in the United States, and how we're going to improve application of LARCs to patients. So this was a prospective cohort study of nearly 7,500 patients. And they wanted to look at what's the real-life rates of unintended pregnancies for, this is pills, patch, and ring, PPR, pills, patch, and ring. What's the real-life unintended pregnancy rate for users of pills, patch, and ring versus LARCs? And they didn't include depot in LARC, which we don't. That's not tier 1, it's tier 2, but their depot numbers were very similar. So you could throw depot into LARC for the purposes of this study. Well, this is important because a lot of the numbers that we cite are a bit theoretical. We know what the perfect use rates are for LARCs. We know what the perfect use rates are for pills, patch, ring. We know what the actual widely promulgated published rates of failure are for pills, patch, and ring, which is 8.4%. But we don't have as good a data on that for LARCs. And one of the problems with the methods is the data that you see typically, even for actual use for LARCs, is if they continue it. But if 25 to 30% of people discontinue Nexplanon in the first year and 12% of people discontinue an IUD in the first year, some of those discontinuers in that first year are going to have pregnancy in the crossover to a new method or with a new method or whatever. So it's been hard to do that. So this study is actually, I think, probably the first well-designed prospective study that answers that question so that you can counsel your patient a real number. And it's 22. You're 22 times as likely in this study to get pregnant if you choose a pills, patch, or ring as you are a LARC, and that's a real pregnancy rate of 4.5%. Now, their population may be a little bit different, and one of the important things is in adolescence, historically, that 8.4% pregnancy rate that we've attributed to tier 2 pills, patch, and ring, in the same studies is 30% in adolescence. So we know it trends higher in adolescence. It trended higher in adolescence here. If you just took the adolescents out of the group, these numbers about double. So if you want to do something about the teen pregnancy rate and you want to have women graduate college without a baby, then implementing first-tier LARC birth control to adolescents is the most important function you can serve. And the hazard ratio for an adolescent, even from this data, is probably closer to 40. Forgettable contraception was another term that these authors were trying to use. You see their depot numbers were similar, but I'm not encouraging depot use, but their depot numbers in this group was similar. And I had this slide up mainly to show you that they almost doubled with the under 21 and the younger it gets. So if you're not aware, and you should tell these things to your patients, this is the recommended form of birth control by the American Academy of Pediatrics, the World Health Organization, the CDC, and the American College of OBGYNs for nulligravid 14-year-olds. And we have to do a better job of that. We have seen a recent drop in the teen pregnancy rate. It's because of widespread use of LARCs. Still, though, they're under-adopted. This is a different study where they looked at complications and side effects and tolerance of IUDs in particular for adolescents. There's several good studies like this that have come out in the last decade. This is why all those organizations are saying this is what you should be using. But they compared Mirena and Paragard and said that basically the complication rate and the continuation rates were similar in adolescents, even nulligravid adolescents, as they were in adult women. And so it's not two separate populations who are going to have two different levels of satisfaction. And overall, Mirena was more likely to be continued and had fewer pregnancies and fewer side effects and less, it makes sense, less pelvic inflammatory disease because of the hormonal effect on the cervical mucus than the Paragard. And we don't have data yet on Skyla, or I understand there's a new, from a different company, a Skyla-like product coming out soon. We don't have data on those, but anecdotally, they tolerate Skyla even phenomenally better than Mirena. So if we were already doing really well with Mirena, and these smaller devices are going to be even more promising, but we don't have a study yet. These were the complications they tracked. The one thing that they noted was that adolescents were more likely to report dysmenorrhea than adult women, statistically. But overall, basically, they had roughly the same complaints, same continuation rates, whatever. The point being, if you would put an IUD in a 28-year-old pair of 4, you should put one in a sexually active 14-year-old nulligravid. They have the same experiences, the same satisfaction rates, and of course, I would encourage you to use a smaller IUD than the Mirena. Or Nexplanon, right? Every adolescent is a candidate for one of the two. This is a different study about provider thought. This is, again, a physician education issue. And they looked at women, they looked at 2,000 providers. About 1,200 of them were OBGYNs or family medicine doctors who were prescribing birth control, and about 800 were Title IX providers. And they surveyed them, and of those 2,000 providers, most of whom are Title IX or OBGYN providers, A third thought that IUDs were unsafe in nulliparous women, and 60% infrequently or never prescribed IUDs to nulliparous women. So this is the education component that we've got to do, and this is why every issue of the Green Journal has something in it about LARCs, trying to educate our providers. Okay, induction of labor. I'm going to go faster now. I've got 18 minutes. I just looked. 1 balloon or 2. So, you know, it's a commercially, the 2 balloon cervical catheter is a commercially available product. So that means it's been sold to us. It's not scientifically supported that it's any better than 1. This study compared a single 60 milliliter old Foley catheter to the double balloon, and they had similar outcomes. Actually, the truth is the Foley group had better outcomes. They had a higher vaginal delivery rate, less infections, less operative deliveries. And so it may be that there's a trend of the double balloon being more associated with infection, and then people getting section because they're infected or whatever. So they actually had better outcomes with the Foley, at least trending towards better outcomes. But obviously the Foley is a lot cheaper. So there's no scientific data that supports the double balloon. Different study, when do you deliver folks who have chronic hypertension? This is one of the better studies that looked at that. It's retrospective, and it's data largely from the late 90s and early 2000s, and it doesn't tease out people who had superimposed preeclampsia, so it's not perfect. But basically, they looked in this large 170,000 group of people, they found that stillbirth rates in women with pre-existing hypertension started to go up after 38 weeks. So if you think of the nadir of neonatal morbidity and mortality for a term uncomplicated healthy person as 39 to 41, it's probably 36 to 38 for a person with pre-existing hypertension. So bottom line, they should probably be delivered right at 38 weeks if you, in the same sense that we would induce a singleton at 41. Speaking of which, ACOG still has a position statement out there that says that we should induce women at 42 weeks or whatever. And that probably needs to change. There's no scientific data really that supports that anymore. This is another great study of 4.1 million births in a registry. And they looked at this, do we induce at 41 weeks or expectantly manage the ones who get there up to 42 and induce at 42? And we've known this for a while. This is just the largest analysis to say it. Same number of C-sections. You section more people though at 42 weeks for meconium and non-reassuring fetal tracings and whatever, and a few more at 41 weeks for failed induction because they just weren't ready yet. But overall, it's the same number. And would you rather section somebody for a failed induction or category 3 tracing with meconium? Lower deaths. Now, this is a decision tree based on the data. These are not real numbers, but based on known rates of complications. But they predicted 4 versus 208 deaths, 41 to 42 weeks, less shoulder dysocias, less meconium aspiration syndrome. It's been the meconium aspiration syndrome and then the subsequent death from meconium aspiration syndrome that has sort of driven us to go to 41 weeks for a decade anyway. But it's probably time that ACOG change it. It was associated with more costs because you're doing more inductions. Inductions take more money. But overall, less costs because of NICU complication and things like that. The downstream total costs were actually less. Multiples. When should we deliver twins? This is something that we've talked a lot about recently here, and there's been some maybe conflicting data. These next 2 papers are actually pretty important. This is actually a pretty sizable study for this issue, and it's only got 235 uncomplicated twins in it, but they were randomized to either elective delivery at 37 weeks or continued expectant management to 38. Kind of like the last study, except it's twins and 3 weeks earlier, 4 weeks earlier. And they found that delivery at 37 weeks for dichorionic diamniotic twins was associated with a reduced risk of a combined aggregate of serious adverse outcomes for infants. And you see a relative risk of 0.39. And so their conclusion was di twins at 37. There had been some retrospective data in the last 3 years that was saying maybe we should go to 38 for dis and 37 for monodis, but this is a better set of data than we've had before, and it's prospective and randomized. So 37. And monodi, there's also been some stuff of should you do 36 or whatever. Obviously, monochorionic pregnancies are associated with greater adverse risks than dichorionic pregnancies. But what they found in this analysis of 1,700 monochorionic pregnancies and 5,800 dichorionic pregnancies was that once you get past 30 or maybe 32 weeks, the risks are the same. So if you're a monochorionic pregnancy that's made it to 32 weeks, you can treat them like a dichorionic pregnancy. The bad stuff, if it was going to happen, was already identified and already happened at that point. So survival and risks were the same after that, and therefore, in their analysis too, monochorionics should also be delivered at 37 weeks. So 37 weeks for everybody, if they make it that far.
The interesting thing about this is ACOG just released a new bulletin in which previously they had 3 bulletins with conflicting information of when you deliver twins. And then their most recent consensus was not 37 weeks, but 38.
I know. And this study is, it's a European study. It's from late 2012. So, yeah.
There is a comment about, your particular hospital, if you have to limit your amount of contraceptive injections and you decided that your needs are
Okay, bed rest. So in 2013, May, I think, of 2013, this paper came out. It's a fantastic paper. You learn all the principles of medical ethics. It's really well written. And it's titled Therapeutic Bed Rest in Pregnancy Unethical and Unsupported by Data. It's a review of Cochrane-level data on bed rest, written by McCall and Grimes, and says that there's no efficacy for bed rest in miscarriage, hypertension, prevention of preeclampsia or hypertension, preterm birth in either singletons or multiples, or impaired fetal growth. And the brilliant part of the paper is the next 2 pages where they talk about the associated risks of it and conclude that if we are offering an intervention that has only known risks and no known benefits, that's unethical. It's a really good paper. One of the favorite things I like in this paper, and I've made most of you residents read it, the interns might not have, but just ask me. They talk about a false sense of agency. We do this to patients a lot. You're at risk for miscarriage, and I tell you to do something that's not scientific, whether it be bed rest or some other intervention that has no data supporting it. You don't comply even a little bit with my recommendation, and you feel guilty for it, or the same for preterm labor or anything else. And the psychological risks to the woman of that false sense of agency are tremendous. A lot of papers, several reviews and other things. This is actually a randomized trial. It wasn't intended to look at this. This is data piggybacked from other studies, Brian Mercer studies on progesterone. But they took 657 women who had ultrasonographic shortened cervix in the mid-trimester who were nulliparous. They all got 17-hydroxyprogesterone based on that. That's what they were studying, was whether or not that had an effect. Different paper. But then women were either on bed rest or limited activity or not on bed rest. And this is the first paper to ever show a statistically significant difference in bed rest versus no bed rest groups. The bed rest group delivered earlier by a factor of 2.3, and that was statistically significant. So the only scientific data that says that bed rest has any impact showed harm for when the pregnancy is delivered. And again, it's a good paper. They analyze some of the other data and call for an end to unsupported practices. This is by Maloney in 2011, and this guy focuses just on, I don't know, it's a guy, focuses just on adverse effects. It's really, I hadn't thought of most of these, so you have to kind of read through it and understand. But for maternal effects, he talks about and has data to support negative cardiovascular and pulmonary changes, obviously musculoskeletal changes, atrophy, protein loss, things like that we think of, negative fluid and electrolyte changes, renal function, a lot of it, and it's well written physiologically, it has to do with changes in where we pool our blood and a lot of different things, but actually observable electrolyte and renal abnormalities, observable cardiovascular and pulmonary abnormalities, very observable bone demineralization, skeletal muscle loss, things like that. Fetal outcomes, multiple papers have shown lower birth weights in the bed rest group. And then the psychological effects are the ones that I think are underreported. Depression, anxiety, family stress, family separation, financial stressors, etc. That's 5 pages by itself. So we're up against this in light of no known benefits. And a lot of cost. It's estimated that right now, a different paper It's estimated that 95% of OBs prescribe bed rest for something without any scientific data and only known harms, and that it costs the system across the U.S. economy between $2 and $7 billion annually. They surveyed a group of MFMs, and 3/4 of the MFMs believed that there was limited to no evidence that it had any value for preterm labor, yet 71% prescribed it for that. And 56% believed that it had limited or no value for treatment of PPROM, and 87% prescribed it for that. So obviously the paper is a comment on how we bridge that gap. Nearly 1 million U.S. families each year are negatively affected through financial stress. I mean, and these are like, I can't make the house payment, we got foreclosed, somebody else had to quit the job to be a child care attendant, whatever. 1 million families a year to the tune of maybe $7 billion are affected by it. Okay, these are the slides at the end where I can go fast because I only have 7 minutes. We've talked about these papers, but there are 3 more papers that came out in the last year and a half that are really foundational and important. So one, of course, is the Hypertensive Task Force. Somebody's already talked about that, so I get to go fast here. But as a refresher, the terms mild and severe have been abandoned. Growth restrictions no longer considered in our assessment of severe features. The growth restriction doesn't matter. Only protein above 300 milligrams matters. No need to ever repeat 24-hour urines. 5,000 milligrams doesn't mean a difference. It's only if you've ruled in with over 300, there you go. Okay, 2 that affect us every day that we got to be mindful of, though. I think everybody's on board with this. If you've had a history of preeclampsia before 34 weeks, or you've had 2 pregnancies past that were affected by preeclampsia, then they should take a low-dose aspirin in their next pregnancy. So that's something you got to think about and get in your pattern when you're seeing patients antenatally. And if a person who had preeclampsia in the pregnancy is persistently hypertensive after 1 day post-delivery, then don't give them NSAIDs because of the adverse effects renally on hypertension. So those are 2 things that are a standard of care that we haven't been doing, so I have to remind myself, got to think about the aspirin or the NSAID. I won't go over this, but this of course is the new system, a little bit different than the old one. There's just preeclampsia, and then you look for severe features. And you can technically have preeclampsia without proteinuria. Most will still have proteinuria, but they really wanted to emphasize that people, just because she doesn't have protein, don't call her severe gestational hypertension. She has preeclampsia with severe features. The protein is not as important anymore. I thought this was clever, new terminology. You all already know all this too, but just to reiterate, this is an important thing, I think, for patient education. You know, they come in, but Dr. Blank in 1991 induced me at, I actually have that patient, induced me at 37 weeks, and he said that was full term. Well, it was back then. So this is deliberate. This is just for patient education. Tell your patients that full term is 39 to 41 weeks. It's still term, the whole time is still term, but these things are meant to be, no. The American College of OB/GYN says that full term is 39 weeks, ma'am, and I cannot electively and deliver you before your full term. That's the point of the terminology, and also to focus on what's the negative outcomes associated perhaps with early term deliveries that we haven't focused on as much in the past, because we've aggregated them all together as term. Okay. Another incredibly important paper is hanging up on the bulletin board. This is from August 2013 by Stephen Clark, and every other MFM in the country that you've ever heard of's name's on it, you know, because it's the network. But how do you manage Category 2 tracings? This is it. This is standard of care now. So the important thing here is, what's the definition of a significant deceleration? You need to know all of this, but if you've not seen this before, it's a variable lasting longer than 60 seconds and reaching a nadir more than 60, a variable lasting longer than 60 and going below 60 at all, any late of any depth, and any prolonged deceleration. The article is well written. I know a lot of you probably looked at the algorithm because I yell at you about it, but read the back content too, where they discuss some of the physiology and the future directions. It's very well written. And this is the algorithm. When your patient has a Category 2 tracing, this is how you're supposed to be managing them. You need to read the text to understand all of it, but this is it. Moderate variability or accelerations, yes or no? Yes, they do. Is she having significant accelerations with more than half of her contractions for an hour? No. Well, just watch her. Yes. Okay, how's her labor going? We're just now inducing her. She's in the active phase. She's pushing. Make a decision. Is the pushing going well? Is the active phase progressing well? We're inducing her and she's already doing this. It's been an hour. Let's section her. She's laboring, but she's well off the curve. Let's section her. She's laboring and it's going really well. She's a para 3 and she's changing. She's pushing and it's going well. Let's just watch. She's been pushing for 2 hours and she's -1. Let's section her. Okay, that's if they have moderate variability. If they don't have moderate variability, it's essentially the same, except you don't get an hour, you get 30 minutes. And it gets you quicker down to C-section if you can't resolve it. That's it. This has the potential of reducing the number of C-sections by 20 or 30%. And it's the most evidence-based document we have on how to do this. This is your standard of care. This is what you'll be held liable to in court as of right now. It'll get better. This author group is already working on new things, looking for data that informs it, but this is the most scientific thing we have. And I was going to end with this. I didn't even make a slide over it, and it worked out because it's 8:58. But the other important article that everybody should read is the one from March 1st or April 1st on the new labor management guidelines. And that's the other great thing that will incredibly reduce our rates of section if they're followed. So active labor is 6 centimeters plus. Arrest of dilation happens only after 4 hours of adequate contractions and after 6 centimeters. So if the chart says she was 5 centimeters and didn't change for 2 hours, and that's called arrest of dilation, not anymore. And also things about prolonged pushing. We delivered one last night who was a 16-year-old who pushed for over 4 hours. That's supported by the new guidelines. She had no complications. That's supported by the new guidelines. The other patient we delivered last night was 2 prior C-sections and no prior vaginal delivery, and she had a vaginal delivery as well. And I was telling the residents last night, those are 2 deliveries that by guidelines wouldn't have happened 5 years ago. Both of those things were wrong 5 years ago. Both of them are women who had uncomplicated deliveries today. We've got to follow these guidelines. They had made these things optional. There's more in that guideline than just that. It talks about how you can diagnose arrest of descent, failed induction, other things that are common pathways to C-section. It talks about version and things like that. This stuff was optional for the last decade. It was, well, if you read that paper, it's probably a little bit better, but we're going to leave it to you. Not anymore. It's written down. It's dogma now. It's what we're held to. And all that, of course, is an aid of reducing the number of C-sections. Okay, I'll take a question.
16-year-old have scleral hemorrhage from 4 hours of pushing?
No.
Good. That would be the only thing.
Right.
That's not a complication, but 4 hours of pushing and a 16-year-old, I would have thought she might have popped a couple of vessels.
Well, it's clinical judgment. If she was pushing that well, you and I both wouldn't have given her 4 hours. But if it's sort of, so it's clinical judgment.
Okay, there's pushing and then there's
Right.
pushing.
Yeah.
The nurses, though, were really, really amiable with her pushing for 4 hours and having a vaginal delivery. They were not in a rush to do a C-section. It was really easy to talk to them and explain it
Yeah.
last night without proceeding. So that was nice.
Anything else? If you want the slides, they're on my Twitter, if you want to look at some of the articles. And I have all the articles, of course, if you want to see them.